first of all, when you have a patient with acute kidney injury or oliguric, it's not equal to fluid bolus. You have to assess your patient because your patient can be completely congestive and adding more fluid. He might need fluid, but you have first to assess it. And I would say that the ultrasound is a key. Now it's key. We can do, if you are more familiar with CVP, with other monitors, that's fine. But I think for ultrasound now it's very accessible. So first thing before giving fluid or removing fluid, the same. Think, assess your patient, and neither oliguria or urinary sodium concentration are equal to fluid boluses. So that would be my first message. So assess the patient before any intervention. To understand how serum creatinine behaves and what are the pitfalls of this biomarker when you draw the graph, of the serum creatinine, how your patient is on this graph, and whether when you see a rise in serum creatinine, is that your patient right now developing acute kidney injury or he did it 3 days ago. I mean, the implication for treatment is completely different. And my third message will be think twice about all your intervention and do not harm your patient with fluids, with inappropriate diuretics, with inappropriate use of kidney replacement therapy, or inappropriate use of fluids. Those are life-saving, but also could be very harmful.